So we were asked to talk about sildenafil, which is Viagra, and non-arteritic anterior ischemic optic neuropathy. So the relationship between sildenafil, but really all of the PD5 inhibitors and NAION, is one of an association which may not be a causal association. So the reason we can't tell in an individual patient whether something is causal is because usually there's a reason you're taking an erectile dysfunction agent, and if that erectile dysfunction agent is being used for a vasculopathic reason, so if you have erectile dysfunction and you're a vasculopath, well, that is a plausible alternative explanation for why you might get ischemic optic neuropathy. So for example, diabetes is a very common linkage between these two entities. So just using the drug itself doesn't make it a cause and effect relationship. Now, having said that, there are some criteria that we kind of look at to help decide whether something is causal or not, and the strength of that association. There are different names for this. The World Health Organization has a causality criteria, and that's possible, probable, definite. There are also criteria used epidemiologically, the Austin-Bradford-Hill criteria, which are very commonly used to help establish on an epidemiologic basis how strong of an association is this and whether you think it is or is not causal. So the first and most important is you have to have a biologically plausible mechanism of cause and effect. And so for all of these agents, these PD5 inhibitors lead to a drop in blood pressure, and for a number of reasons that are psychosocial and cultural, the agents tend to be used right before sleep. And so nocturnal hypotension is a potential linkage with the mechanism of non-arteritic anterior ischemic optic neuropathy. The agents are known to drop the blood pressure by a few millimeters of mercury, so that's a biologically plausible mechanism. Hypotension. It also looks just like NAION, and so it has to be something that's very specific, and non-arteritic anterior ischemic optic neuropathy is not very specific. And as I mentioned, there's an alternative possible causation with the cause for the ED. However, there are cases where the person had no risk factor. They were just using it to enhance performance, and they had no vasculopathic risk factor. Those are stronger cases. You have to have a close temporal relationship between the cause and effect, and that relationship has to be coherent with the pharmacokinetics of the agent. So we really can't have taken the agent and then a year later you get NAION. That's not related because the half-life of that agent is relatively short. So most people would say the limit is going to be weeks, 30 days maybe, is going to really be the limit for a 5 half-life washout for this agent. And the strongest cases are going to be within hours of taking the agent. So there are clearly cases where the person took the drug and then 2 hours later, or they woke up the next morning with NAION. There has to be analogy, and analogy means you can't be the only patient that has this. There have to be other people that have it, or there have to be an animal model. We really don't have a good animal model for NAION related to PD5 inhibitors, and therefore we have to rely upon analogy. There's multiple cases that have been reported in the literature from other people who have NAION and the PD5 inhibitor. You have to have a specific effect, and I already told you that NAION is not that specific effect, and you must exclude the possibility that it's chance alone. It'd be better if we had a dose response curve. That is, the more you take, the more likely you are to get the effect. And we know that from other drugs where the causation is much more clear. For example, in ethambutol toxicity, where 15 mg per kg, you're starting to get increased risk. By the time you get to 30 mg per kg of ethambutol, you're talking about 6 to 8% chance of going blind. And there are different types of dose relationships that are in the literature for other ocular toxicities. For example, hydroxychloroquine, where there's a cumulative dose effect of 1 kilogram, and the dosage mg per kg starts to rise as soon as you get over 5 mg per kg, but certainly as high as 6.5 mg per kg, you're getting into risk of toxicity. So that's called dose responsiveness. And then the last is the rechallenge, dechallenge. A rechallenge means you take the drug again and you get the exact same thing. A dechallenge means you take away the drug and it gets better. So we do have some rechallenge cases for this from people who were dumb and just took it, got vision loss, and then just did it again to themselves. So if you look at these criteria, a biologically plausible mechanism, a close temporal relationship between cause and effect, dose specificity, the absence of alternative etiologies, including chance alone, coherence within class, all the drugs in the same class do the same thing, analogy from other people, dose response curve we don't have, re-challenge, de-challenge, we have a few iffy cases. So I would say the relationship is still possible but not proven. In the case control study, observational crossover that was done, the risk is probably between 2.1 and 2.34 increased risk. So it's 2 to 2.5 times higher in a small number. So I always tell the patients about the risks. If they've had NAION, I tell them they have to make a risk-benefit decision whether they want to continue the drug, and you should know that PD5 agents are associated with NAION.